Welcome, everyone. I'm so honored to be here, so honored to become a member of the Accademia and the Lincei. And I will start, without needing to hear all the recitation of degrees, by introducing myself. But I also need, here we go. Okay, well, I grew up in the very remote but beautiful Wind River Mountains of central Wyoming. My grandparents came to America from the Alto Adige. So you can see that they found a country that, at least as best the United States can do, reminded them of home. I studied immunology. I trained in surgery in Boston. I was fortunate for many years to have a laboratory studying the role of inflammation in tumor formation, particularly as it related to a rare genetic disorder called familial adenomatous polyposis, which carries a very high risk of colorectal cancer, duodenal cancers, and some nasty sarcomas known as desmoid fibromatoses. My focus has always been translating results directly from the laboratory into the clinic. So it was not a surprise that about 15 years ago, I began coordinating very large, increasingly international clinical trials for people with cancer, eventually leading to a large international clinical trials network. However, in 2022, a little over 2 years ago, President Biden asked me to be the director of the U.S. National Cancer Institute, and just 6 months after that, asked me to move to fill the position formerly held by Dr. Francis Collins, the director of the National Institutes of Health. So I took the Oval Office for this position just 1 year ago, and today I am thrilled to be at NIH, where everything that we do revolves around doing just one goal: to improve the health of the American people and people everywhere. So here at NIH, we seek fundamental knowledge about the nature and behavior of living systems, and we strive to apply that knowledge to improve health for everyone. The NIH is the largest public funder of biomedical research in the world, with a current budget in 2024 of just under $50 billion US. The seeds of NIH began in 1887 with the establishment of a one-room laboratory of hygiene, which eventually became part of the U.S. Public Health Service. And in 1940, President Franklin D. Roosevelt dedicated our large new campus in Bethesda, Maryland. And in 1944, there was a law created by the U.S. government to maintain constant funding for the NIH programs. Today, we conduct research in our own laboratories in Bethesda. We support research of non-federal scientists in universities, medical schools, hospitals, research institutes throughout the United States and the world. More than 85% of our budget goes outside of our institution across everywhere. We help train research investigators from across the world, and we also have a very important role I'll talk about a little bit later about fostering communication of medical information. NIH has 27 different institutes and centers, each with its own mission, budget, priorities, leadership, and strategy for how they use their money. Most support both research outside of the NIH as well as their own research laboratories in our NIH campus. So let me just take a breath here and talk a little bit about this heuristic, a very large 30,000-foot view of health and disease. It considers some of the biological programs that are required for human beings to grow, develop, and maintain their health. We develop from a single cell, and our biology constantly changes as we transition through various life stages, from infant to older adult. And to keep us healthy in the face of so many demands from our environment that also constantly change, We must be able to renew epithelium that provides a barrier to the outside environment. We have to heal wounds in complex tissues. We have to respond to infectious agents of so many kinds. We have to maintain the integrity of our DNA, function in the face of fluctuating nutritional inputs, have a mechanism to survive despite feast or famine, and we must detoxify harmful substances. To name just a few of the incredible things our bodies do every single day. And when any of those get thrown out of whack, we get disease. So this heuristic reminds us of the value of fundamental research as it addresses the underlying principles that span multiple organ systems, multiple diseases, and it particularly reminds us always to think across the lifespan and across diseases and disciplines as we design and conduct our research. Increasingly, this sounds crazy, that you would think of the human being as a whole organism, because traditionally we've all spent time in our own little disciplines. But technologies now, new data analytics, new approaches are allowing us to view a much more holistic version of human health that can truly now tie the laboratory to the clinic. It's a very exciting time. So we're very proud at NIH of our unique hospital. It's the largest clinical research center in the world. It only sees patients as a part of clinical research, particularly patients with very rare diseases, those for which NIH has a promising clinical trial. These patients come from across the world to be treated at the clinical center. Immunotherapy for cancer and autoimmune diseases, gene therapy for metabolic and neurodegenerative diseases, new approaches to vaccine development for a large variety of conditions are just a few of the major programs that are underway at the clinical center. The clinical center is also unique because laboratories focused on basic science research and the patient clinics all exist under one roof, all exist on one campus. So somebody studying the molecular biology of progeria, a rare disease that causes premature aging, are right on the same campus, just one building over from the people who are running a clinical trial of new gene therapies or drug therapies for people with progeria. We believe that that very close interaction between the fundamental laboratory and the clinic is critical for success. Science, it takes many years before a strand of fundamental knowledge, which might at first be of interest only to a very small number of academic experts, all of a sudden jumps up and leads to a new treatment. Of course, the entire world saw this with new mRNA technologies being able to rapidly deliver vaccines. It is impossible to predict where those important discoveries or insights will take place. It's also, we've tried, impossible to predict who will deliver those wonderful results. They can come equally from a researcher in a small laboratory in some relatively modest place than from the largest biomedical academic center. So it's another thing we take very seriously is to make sure our funding reaches a very broad range of people. And this is also why NIH spends more than half of its budget on a broad and very diverse research portfolio. We know this maximizes our chance of breakthroughs. This chart shows the largest area of NIH research. The largest amount of funding, just about $8.1 billion this year went for cancer research. The same, very similar for infectious disease, but we also recently have very strong emphasis on women's health, the dementias, cardiovascular disease, substance misuse, also tied to mental illness, which are now the fourth largest area of research. This is a very important principle I've already alluded to. NIH research encompasses the laboratory, the clinic, But increasingly, it does not stop at the door to the clinic. It extends deeply into the communities that we serve. A little bit more about this in a moment, but we have increasingly understand that income, age, race, ethnicity, geographic location, disability status should not be barriers to participating in research or benefiting from research advances. If people do not participate, we know more and more they cannot benefit. In keeping with this principle, NIH research is very, very broad. It ranges from the highly technical. I think our last speaker probably recognizes some of the technology leading to this here. This is new methods in cryo-electron tomography that allow direct observation of protein dynamics in the milliseconds to seconds range in real intact tissues. Here you see an epithelial cell, on the far left an epithelial cell, at the very top the nuclear membrane and adhesion junction, and then those orange gold colored cells in the bottom are blood within a vessel wall. Absolutely incredible what we can see in intact tissue now as never before. But on the other end of what we do, our work also is community focused. So we work in partnership with our Native American communities to combine traditional healing ceremonies with drug therapies for those suffering from chronic pain and depression and substance use disorders. Our scope of research is incredibly broad. This is probably the most important principle for all of us. We keep it in mind every day. Our work is not finished when we deliver scientific discoveries. Our work is only finished when all people are living long and healthy lives. And we've got a big problem. We've got a big task for this. I'll just speak to the United States right now. In spite of its wealth and astounding range of different therapies available to people to treat so many diseases, U.S. life expectancy is poor compared to our comparator nations. And this is even though the overall cost of healthcare is so much higher in the United States, currently 17.3% of our GDP. And here's the even more embarrassing thing. Many reasons for lower life expectancy in the United States are associated with geographic location. This map, green is good, red is bad, yellow is not so good. This map of life expectancy mirrors what we see as disparities, deficiencies in cancer survival, the rates of obesity, substance use disorders, and also deficiencies in healthcare access, lower socioeconomic status, and so many other factors we know are very much related to health. We must also pursue regional variations in diet, tobacco use, and poor health literacy, as well as technological innovations that address how environmental factors present in specific communities, such as toxic exposures, regional effects of climate change, affect our cells and tissues in ways that truly influence health. So what are we doing? What is NIH doing? A new initiative across all of the institutes and centers. So every disease state allows clinical and translational research to connect with who? Not the experts, the primary care doctors, the clinicians on the front line and their patients, to give them access to research and the opportunity to participate in clinical trials. Many communities have poor health, and it's not just one type of health program. We can't go into an extremely poor community and say, we're only here concerned about your cancer risk. We have to be concerned about everything, and that is what this new program is doing. Ultimately, we believe that this will have meaningful impacts on health outcomes, especially in those parts of the country where people have historically been underrepresented and underserved. Another priority for us at NIH is better integrating data from basic and social science research, public health, and clinical care. Our progress is accelerated when advanced scientific methods such as new data analytics are applied to data that includes everyone, and when new discoveries are rapidly and equitably adopted then to help people who need them. The National Library of Medicine is probably best known for housing the searchable publication library for biomedical research known as PubMed. The library began in 1836 as a collection of books and journals. In 1968, it switched from being only a collection of books to serving as our National Center for Biotechnology Information. And over the past 25 years, the National Library of Medicine capabilities have expanded to support large, publicly shared research databases containing information on chemical structures and their biological activities, protein sequences, protein structures, chromosomal aberrations associated with disease, genes and gene expression, pathogen surveillance, particularly for drug resistance, and clinicaltrials.gov, a database of both privately and publicly funded clinical studies across the world. However, this is not enough. Our world of data has changed so dramatically over recent times. We need to ensure that we now have a data ecosystem that works for us in 2025 and beyond, and truly works for the world. New machine learning approaches, now so widespread, have dramatically changed the way we all think about data sharing and data use. We're at an inflection point right now. Data are scattered across various entities. We need to move to a larger, shared space that is both secure and sustainable. A new effort is dramatically expanding the programs and capabilities of the National Library of Medicine to make it the epicenter for NIH-funded research to advance information science, analytics, and data science. 2 years ago, in January, we issued a requirement for every laboratory, every grantee who receives funding from the NIH must make their data available for sharing and use by everyone else. But how are we going to do that? It's easy to say, a challenge to do, and a challenge that we intend to meet. So this work will integrate data from basic and social science research, public health, clinical care, increasingly data that comes through many arms of the US government for health. It'll increase the capacity for data hosting, enable low-cost access to data using open industry data standards. We are promoting, in fact, demanding that we not have clinical data silos that are exclusionary. These data need to be shared. And support broad access to advanced analytics and computational pattern. This will be a federated data architecture. Researchers will keep their own data. Health systems will keep their own patient data. But we have the ability to bring it all in and use it to address specific questions. By catalyzing this shift to a federated biomedical research data sharing infrastructure, I am very confident that we can significantly accelerate advances that will truly improve health. So I am going to end there by just saying again what a tremendous honor it is for me to represent the many people of the NIH in this presentation today and in this wonderful society, and to be asked personally to join this society whose members have so long brought so much to the world. Thank you so much, and I look forward to a long and fruitful association with the outstanding members of the Lincei. Grazie.
Thank you so much for your interesting introduction, particularly to your institution, now that we are all part of our institution.
Absolutely.
And I'm grateful for that, and ask the audience, Carlo Patrono.
Thank you, Monica, for a very interesting presentation of the NIH. I was impressed by the fact that the budget allocated to cardiovascular research is only 1/3 of the budget on cancer and infectious diseases.
Yes.
What kind of factors go into establishing a priority and budget allocation?
Oh, what a wonderful question. The US Congress decides. Every single one of those budgets are not set by me. They're set by the US Congress. But it's not as bad as you think, Carlo, because the director's office, I have a good budget of my own, not as big as the big institutes, and my budget is all of my budget goes for projects that work across many of the different institutes and centers together. And what has happened, this has been possible now for about 20 years. And what happens now is approximately 1/3 of the research is now done in collaboration across multiple different institutes and centers. Let's see, cardiovascular disease, very, very critical partner with the Cancer Institute for transplantation, cell-based therapies and transplantation. Also, Cardiovascular Institute receives much funding in collaboration with the National Institute of Allergies and Infectious Diseases for its work in the effects of COVID on the heart and lungs and cardiovascular system. The Neurologic Institute is also involved in a huge brain initiative. You get the point. So even these institutes whose individual budgets are smaller are greatly amplified by a significant amount of funding that allows cross-institute work. I wish we could have a better say, frankly, over exactly how much money is spent where, but this helps. Thank you.
Okay.
Paolo Giubellino. I'm new, so you are not. You are excused not to know the name.
Benvenuto anche.
Yeah. A bit of a corollary to this question. You were extremely effective in reminding us of how a key role in overall medical research NIH plays. And so an obvious question that some people might ask themselves now is how much of the agenda of NIH is dictated by political power?
So I take a deep breath here. I spend 30% of my time, 40% of my time at Congress. That's my biggest job. Talking, arguing, advocating, describing, explaining. And I get just as much support I get equal support from both parties. I can say that completely, at least up until now. We have wonderful supporters on both parties. There are times when one party will be in power, and so certain things that we do will be forbidden. And then as soon as the next party is in power, those things will come back. I'll give you examples. Stem cell therapies, In the Bush administration, gone. Obama administration, back. They're still back. Things like that will happen from time to time. It is my job to represent science in that and to argue on both sides whenever they want to make some change, argue for ways that it could be better. The other thing I work really hard right now is I also argue for positive changes. So right now we are working very hard on requirements that every citizen in America who goes into their physician's office is asked, can we use your data for research? Because we don't want to take people's data without their permission. I mean, we can do that for public health reporting. We can't do that for research. It's not, we do not believe that's ethical. So Congress right now is working on a bill that I'm trying to get them to pass that says you you can't compel someone to give their data for research, but you have to ask them, at least. And then the second question we're going to require that they ask, and you'll see how powerful this is for anyone who treats a rare disease, is, okay, if you let us use your data, if we find something or have something that is relevant to you, can we contact you again? And so anyone who has a child with muscular dystrophy or, some rare kind of cancer or so many people we know from our experience will say, yes, yes, please let me know. And so that direct communication with people, we have never had the ability to do at a national level. So I'm hoping our Congress will agree with that one. Yes.
Remuzzi, may I?
Il professor Remuzzi.
Sì.
Grazie.
I like to echo the Carlo Patrono questions. The number one disease in terms of number of people affected in the world is kidney disease. Now, in this moment, we have 800 million people in the world suffering kidney disease, 40 million affected by cancer, 400 million with diabetes. 50% of them have kidney disease, and those who die are those who have a kidney disease. And this is number one. I think it would be nice to advocate for these people, because what is normally assigned to kidney disease is a teeny, teeny, teeny fraction of what is done for everything else. And number two, I read a paper in the New England Journal of Medicine. I was very impressed after COVID. They said we need a national health system for everyone. We have a national health system here in Italy, where you are a member of the Lincei now. We have our own problems, but it was fascinating by reading the idea that after COVID, your country discovered the need of a national health system. Posso avere, intanto che ho il microfono, un minuto per Mario Stefanini? Io ho avuto tanti ammalati, ma come Mario Stefanini...
Prego.
Posso?
Prego, prego.
Non ho mai visto nessuno. Critico...
Prego, siamo in chiusura, siamo aperti, no? Quindi
sì,
non abbiamo limiti. Non abbiamo limiti, eh?
Non volevo disturbare, ma volevo dirvi quanto
Nessun disturbo.
Mario Stefanini sia stato un ammalato esemplare. Lui era lucido, critico, attento, sereno, incoraggiava i suoi medici. Nella mia esperienza è stata una persona meravigliosa, volevo spendere una parola per lui.
Grazie.
On the way to... Finito? Oh, please.
Sorry. Monica, thanks for your overview. My question is, after living over many different periods of my life in the US, from California to Midwest to New York, I've always noticed that there was, I'm not there now, but a shortage in the prevention area.
Yeah.
And especially in the free prevention, that is one of the best thing that I think we have in our healthcare system. Is this something you would have the possibility to advocate for in the US healthcare system?
Yeah, it is an economic problem. Our challenges with our healthcare system, to be fair, are largely economic. And prevention has not been viewed as a priority because of, frankly, the way the economics work. But I can tell you that the entire biomedical research community is so strongly advocating for this. This is also one of the reasons for this community, you can see this community network, because it is finally, we've spent, in my opinion, too much time or too much emphasis on all of our specialists. And you go to a specialist when you're already sick with something. You don't go to they're not the people who do prevention. So this new network, which is designed for the family doctor, the person who sees you before you're sick, or maybe when you just have risk, because we now have a research network allowing us doing that, that is our big hope for being able to finally get the research behind prevention. Then we can make the case for the funding and support of the work that it takes to do the prevention. So thank you for it. It's a very important question.
The next question is from our president.
I have a comment and a question. A few years ago, a colleague of us made statistics about the life expectancy of the Lincei members. And it was among the highest in Italy. So for the new members, hopefully it's a good expectation. The question is that I was impressed by the low life expectancy in the US, much lower than in Europe. And I was wondering, looking the map, how much this is related to genetic reason or also to environmental reasons. For example, there are areas in which there may be also radon from the ground, gas emission from the soil, and I mean, the environment may play a role in, I wonder how you deal with it.
Yeah. So far, everything we know tells us that this is environmental, not genetic. Everything that tells us so far. And we finally have the data for this, that it's still early, but very conclusive in the All of Us program that Francis Collins started, you know, germline DNA from everyone in every corner of the United States at a scale, over 1 million people, to be able to analyze it, and then to link that to their health over many, many years. And it's zip code, location. And so you're right, it's, do you live next, is your house next to a freeway where you breathe fumes all day, or is it, you know, you work in the field and you go in the sun all the time, you get a melanoma. All of those factors are critical, but I think even more are the lifestyle health factors, the food. Another one, very terrible, maternal health. Women, in that bad part of the map, women die in pregnancy at a rate of 2 to 4 times higher than in other places. It's just, like I said, this for me, in my particular job, is an emergency, because what it tells me is all of these are preventable causes of death. So we need to give them much more attention than we ever have before. So thank you for that.
Thank you.
Thank you.
Are there any other questions? Okay, there.
Comment and a question. Of course, I thank you for your talk, because it's fascinating to see how NIH remains what I remember it was, so such a beautiful place. And my question is more, you as a director, how difficult it is for you, or it was, to keep science at the first place in your work?
Oh, so that actually is not difficult at all, because that's my only job, right? Or if you mean, I don't know what you mean by science. You know, everything is science. Everything we do is science to serve humanity. People ask me, how can you run a $50 billion U.S. agency? And I'm not a nephrologist, I'm not a cardiologist, and I remember when the White House called and they said, we want you to move from NCI over to NIH. I said, no, I cannot do that. I don't know anything about diabetes or any of these other things. Don't ask me. I'll tell you how. Every Tuesday morning, 2.5 hours, I have a meeting with all 27 of those directors, and we sit 2.5 hours every week, and we talk about what all the problems are, and we talk about, I think to the benefit of some people who worry about that funding, how we are all going to work together, and how the programs are going to collaborate, and what's exciting. And it's thrilling. So that's how science is always. The last thing I want to say, if I can, is the other thing that keeps me up at night all the time are the young people. People who are just starting out. We had a pretty bad year because the US government did cut our funds this year. And so who gets hurt whenever there's a bit of a down? It's always the new people, always the young people. So that's the other thing. There are 2 things we talk about in every single meeting. One is, you know, what's the next collaborative project? And 2 is, what are we going to do for the young people? So it's a great honor. Thank you.